Hey guys, welcome to Man Medicine, where we talk about how men can optimize their health and escape the collapsing U.S. healthcare system. Well, today we're going to talk about one of my favorite supplements, favorite electrolytes. It's magnesium. I use a lot of magnesium actually in my emergency medicine practice, and any physician or nurse that works in the emergency department, in the ICU, and even up on like a med-surg floor, you're going to be familiar with what I'm about to tell you. It gets used, in my world a lot for a number of different things. One of which is a crashing asthmatic patient. When you've got an asthmatic patient that's going down the drain, you are throwing everything and the kitchen sink at that individual in an attempt to try to reverse their condition and try to avoid putting them on a ventilator for a lot of different reasons. Magnesium is one of those things that you can throw in there that has some effect in severe bronchospasm. It can help relax smooth muscle, that sort of thing. It gets used a lot in the obstetrical world to treat preeclampsia or preterm labor. I occasionally use it for that in the emergency department. It's used to treat cardiac dysrhythmias, particularly serious life-threatening ventricular arrhythmias. Polymorphic ventricular tachycardia is just one of them. So I occasionally use it for that. But really, I use it commonly because so many of my patients are magnesium deficient when they come in to see me, either chronically or acutely. Many of my patients are chronic alcoholics, they're morbidly obese, they're diabetic or pre-diabetic, and they are on medications that predispose them to low magnesium, and usually they're a combination of all of those things all at once. And on top of that, they might perhaps have a gastrointestinal illness that has tipped them over the edge. And so I see some really critically low magnesium levels sometimes, and I always have my radar out for it because it's something that's really easy to fix, and can make a big difference on somebody's hospital course if it's addressed right out of the gate in the emergency room before they get admitted into the hospital. So that's kind of the more serious aspect of low magnesium. But the fact of the matter is that the majority of the United States population, as I'm going to show you with some data here, does not consume adequate amounts of magnesium. And there's a number of different reasons for that. We're going to get into that. Low magnesium also has a number of serious potential cardiovascular implications in the long term. And I'm going to show you some data on that. A lot of people are not aware of that. So magnesium is critically important. So let's move on to, I'm going to talk about this first paper here. This is where a lot of the statistics I'm going to show you are coming from. This is from a special article published in Nutrition Reviews. Suboptimal magnesium status in the United States. Are the health consequences underestimated? And they lay out a pretty good case that they are underestimated, and we'll talk about that here in a little bit. But they define a low magnesium level in the serum as being less than 1.8 milligrams per deciliter. And we'll talk about why it can be a little bit problematic sometimes in chronic cases, but I agree that that's generally a good cutoff. And I routinely see numbers under 1.8 milligrams per deciliter in the emergency department. They call it severe when it gets down to 1.25 milligrams per deciliter. Low magnesium is incredibly common in my world, as I was alluding to earlier. If you're sick enough to get into the ICU, which many of my patients are, then it's 50 to 60% prevalence of low serum magnesium. And again, it's something that's so easy to treat. I do it all the time, with intravenous magnesium. Many of these people are so sick they can't be orally replaced, or they have such a large deficit, and or the acuity of their condition is so high that I need to replace it, quickly with an intravenous, usually a bolus of like 1 to 2 milligrams of magnesium, and they may need more, as time goes on. But there's a number of different medications out there, specifically diuretics and proton pump inhibitors. So those are your acid suppressing medicines, many of which are now over the counter that people take chronically that can impair magnesium absorption. So there are a lot of people who are chronically magnesium deficient for no other reason that they're on one or more of those types of medications. The thing that's interesting though, diabetics are particularly prone to low magnesium just by virtue of their condition, and this includes pre-diabetics, and it has to do with insulin resistance. And I'm going to show you the mechanism how that happens here shortly. But if you took a pool of diabetics, depending on the studies that you look at, they quote in this article anywhere between 9 and 47% prevalence of hypomagnesemia, low serum magnesium in type 2 diabetics. It's not because they're on a number of these medications that impair magnesium absorption. It's actually something that's inherent in the condition. And again, I'm going to show you the mechanism here in just a minute. So this is a chart from that article just showing how woefully inadequate dietary magnesium levels are in the US population across various age groups. So they have two columns here on the left side, the recommended daily allowance and then the estimated average requirement. Doesn't matter which one you focus on, but we'll look at the estimated average requirement. You can see that, as you get older, it goes up. It's not as high in childhood, but then, once you get basically into young adulthood and beyond, the RDA, for example, gets up around 400 to 420, and then the EAR is somewhere between 340 to 350 milligrams per day. But scoot over to the far right side here. This information is a little bit dated here, but there's no reason to think it's not still accurate. In particular, I want you to look at, in both men and women, the 14 to 18 year age group here, because they tend to be the worst. So 68% of young men age 14 to 18, 68% of them are not getting an adequate amount of magnesium. They're not even getting 340 milligrams a day. It's way worse for teenage girls. 89% have inadequate dietary magnesium intake. And honestly, as you go through the age groups, moving on into the elderly years here, it doesn't get a whole heck of a lot better. And there's a number of different reasons that they postulate for this, including magnesium depletion in the soil and increased intake of processed foods. Obviously, processed foods tend to be low in a number of different micronutrients, and magnesium is not the only one. But this is an extremely common problem. And as I'm going to show you, it may have some serious potential health consequences that I think maybe are underappreciated or perhaps ignored. And this is such an easy fix with supplementation that I think it's something folks should consider doing. So this is just another chart here showing very similar data. After the age of 14, over 50% of both men and women get inadequate amounts of magnesium. So this is not good. This is not good. This is an interesting caveat that you guys at least should be aware of. This comes from the journal Nutrients. It's a 2018 article. Magnesium, are we consuming enough? They also state some of the similar information that I just showed you guys, that across various age groups, dietary intake in most Americans is woefully inadequate. But they make an interesting point here that I think it's important to know. The serum magnesium, the standard serum magnesium test that you can get at your doctor's office, and the one that I do in the emergency department, it may not be the best test for people who are chronically deficient, because it may be artificially high. Most of your magnesium, at least 60% of it, resides in the bone, and so your body really struggles. It wants to keep a normal serum magnesium level, and so it will leach magnesium out of those stores in the bone in order to do that. So sometimes that initial serum magnesium level will be perhaps falsely elevated, despite the fact that your total body magnesium levels are quite low. Your tissue magnesium levels are quite low. Magnesium is a mostly intracellular cation, meaning it is in higher concentration inside the cell than it is outside of the cell. So they recommend that if you really want to get a good idea of what your magnesium levels are, you can get something called an RBC magnesium level, which they measure the actual amount of magnesium inside your red blood cells. And that can be a better indicator of really what your actual magnesium status is. I don't find it particularly useful, but again, if you really want to get down to the nitty gritty and really find out what your magnesium status is, that's probably the best way to do it, at least according to this article. And they're recommending levels between 4.2 and 6.8 milligrams per deciliter. Many experts say that it should be at least 6. So something to consider. The other thing that they mention here is let's say you don't have access to this test, which, I can order this in the emergency department, but it doesn't come back for a couple days. So for me, it's pretty useless. So I just have the serum magnesium level. But they say that, if your serum level comes back at around 1.8 or what they use the number 1.82, then odds are over 50% that you probably have total body serum magnesium deficiency, even though, because that's right at the low end of normal. But if your levels are above 2 milligrams per deciliter, then you're probably okay. So, you can feel good that your levels are probably good. Maybe you don't need to supplement at that point. But, if you're down around 1.8, odds are that, you may benefit from a higher magnesium intake. Okay, this is this is something that I learned the hard way as a medical intern. Potassium and magnesium are intimately related and connected, and it can be very challenging if you have a low serum potassium level to get that level back up to normal if you don't also correct for serum magnesium. And any of you MDs out there and RNs with some experience under your belt have probably had the experience of giving boatloads of potassium to little old people with very, very low serum potassium levels, and seeing that potassium level just barely bump or not go anywhere. And you're like, what the heck is going on? Well, it's because you also have to replace magnesium. If you want to get into the nitty-gritty of the science behind why this happens, this is an excellent article here from 2007, the Journal of the American Society of Nephrology, Mechanisms of Hypokalemia and Magnesium Deficiency. I'm just going to show you this little drawing here because this pretty much explains all of it. So there are these little channels that allow potassium to leak out of cells and into the tubular lumen in the kidney, so it allows you to secrete potassium. So they're called renal outer medullary potassium channels, ROMK is the other name for them. So as you can see from this article, on the inside of the cell, you have a bunch of potassium, which is these little Ks here, and then magnesium. Well, when you have sufficient amounts of intracellular magnesium, the magnesium, you can think of it as sort of plugging up the hole here in this channel. When it binds into this channel protein, it's much more difficult for potassium to leak out into the urine and then be excreted out of the body. But if you don't have enough magnesium floating around inside of your cell, that channel is wide open and you're just secreting potassium. You're just losing it in the urine, and you're not reclaiming it back into your body. So this is why when you've got somebody, if you're a physician, especially on the inpatient side or in the emergency department, somebody who has a critically low potassium level, you really need to get a good look at their magnesium level, and you need to correct that first, or else you're just not going to make any headway with replacing their potassium. So, and this is the reason why. Okay, this is an excellent article here. I want to talk a little bit about some of the complications of low magnesium in terms of cardiovascular disease and type 2 diabetes. This is Endocrine Reviews. It's a 2023 article, so hot off the presses. Hypomagnesemia and cardiovascular risk in type 2 diabetics. It's an excellent article. It's going to talk about the fact that low serum magnesium has a number of consequences that perhaps we were unaware of in prior years. So just right out of the abstract here, they say hypomagnesemia is 10-fold more common in individuals with type 2 diabetes than in healthy populations. And again, I'm going to show you the mechanism here in just a second. Hypomagnesemia is associated with insulin resistance. Absolutely. Okay. Magnesium supplementation decreases type 2 diabetes associated features like dyslipidemia and inflammation. Exactly. So if you have low serum magnesium and you replace it back up to normal levels, you actually improve insulin resistance. You can improve lipids, not by a lot, but you make some improvements there, and you can see a decline in a number of different inflammatory markers, interleukin 6 and high sensitivity CRP, all of which have an association with cardiovascular disease. And all of that just by replacing magnesium, which is dirt cheap. Okay, it's a very simple intervention. And then it goes on here, this is even more interesting. Epidemiological studies have shown an inverse association between serum magnesium and the risk of developing heart failure, atrial fibrillation, and microvascular disease and type 2 diabetes. So this just shows just how critically important to life magnesium is. And having a healthy magnesium level can go a long way to helping you avoid many of these serious complications from type 2 diabetes and from heart disease just by replacing serum magnesium levels. So it's really interesting. It's a great article. Okay, why does type 2 diabetes and we're going to lump in prediabetes here because it's an issue with insulin resistance. Why does that cause low serum magnesium? Well, first of all, we need to talk about how common type 2 diabetes and prediabetes is in the U.S. population. We're at the point now where we're approaching, and we may have actually surpassed it now, a 50%. 50% of the U.S. population is either diabetic or pre-diabetic, which is unbelievable and it's pathetic. And that's why I'm telling you guys this healthcare system is going to collapse. We cannot support this. And that number, tell you, it's only going to go up. I already mentioned how common in type 2 diabetics, up to 40+% of type 2 diabetics have low serum magnesium levels. And we used to think that this was simply because, when you have high serum glucose levels, you tend to spill over urine, spill glucose into your urine. The urine causes polyuria, right? So when sugars are high, diabetics tend to urinate more frequently, and they thought, well, it just pulls the magnesium along with it. Well, it turns out that's not the case, and we know that's not the case because we have these new drugs on the market called SGLT2 inhibitors, which their job is to actually block the reabsorption of glucose in the urine. So it actually causes you to urinate out more glucose, and those are not associated with a lower serum magnesium level. In fact, through a mechanism I'm not quite sure I understand yet, it can actually raise magnesium levels. So this isn't just a diuretic or like an osmotic effect. There's actually a more complicated reason why magnesium levels are low in type 2 diabetics. And this little diagram here explains that in a kind of in simple fashion here. So on the left side, you've got the prourine, which is, this is in the distal convoluted tubule. This is in the kidney, so where you're making your urine. And then you have a cell here, and then on the right side of the cell, you have the blood. So the most important thing to look at here is this top part here. Well, we have this connection here between the insulin receptor and this TRPM6 and TRPM7 channel. This is what allows magnesium that's filtered out into the urine to be brought back into the cell and then brought back out into the serum again. It allows you to reclaim your magnesium. And this is where the issue is in type 2 diabetics and pre-diabetics, is because you have insulin resistance. These GLUT4 receptors are not very prevalent. So you lack a sufficient number of these receptors, you're not going to have a lot of influx of magnesium coming from the urine into the cell. So that's a problem. And then it gets worse from there because, the mitochondria that are in the cell that are required to generate ATP, well, the generation of ATP is a magnesium dependent process. So now you've got a problem with cellular ATP and energy levels. And it's this ATP that comes over here and powers this sodium potassium ATPase. This is the little powerhouse ATPase, which cleaves ATP as energy, and what it does is it brings sodium into the cell, it pumps potassium out. It's what creates this electrical gradient between sodium and potassium, which is essentially required for every process necessary for life. It's critically important. Almost all life on Earth, as far as I know, has some version of the sodium potassium ATPase to create this kind of electrical gradient. So without that, you're dead. Okay. And then you have this channel just below that. As sodium comes in, magnesium is exchanged for sodium. So all of this is screwed up if you have a issue with insulin sensitivity. And so this magnesium that normally would have left the kidney, been brought into the cell, it just gets excreted out. Now, to compound things, as I alluded to earlier, not only do diabetics and pre-diabetics have this fundamental problem here that causes low magnesium, but many of them, if not most, are also on additional medications that compound the problem. So it's not surprising to me that I see so many, obese diabetic and pre-diabetics in my emergency department that have low serum magnesium, because they've got multiple things working against them in terms of maintaining an adequate, healthy amount of magnesium. Okay, let's talk about heart disease a little bit. This is an interesting study. I believe it's still ongoing. The atherosclerosis risk in community studies. This is from the Journal of the American College of Cardiology. And this is a really large cohort study. It's over 14,000 white and African American men and women aged 45 to 64 years old that they followed over time, at least 12 years. And they just kind of looked at rates of sudden cardiac death and rates of heart failure, rates of myocardial infarction. And then, we're looking for trends essentially. And what they found was a twofold increase in the incident rate of atherosclerosis and coronary artery disease and myocardial infarction when you compare the group with the lowest amount of magnesium to the highest amount of magnesium, meaning the group that's in the lowest quartile had twice the rate of those cardiac complications as the group that was in the highest quartile. So there's definitely some sort of association there. And then that also applied when they looked at heart failure, the development of congestive heart failure, whether it was heart failure with preserved ejection fraction or heart failure with reduced ejection fraction. It was the trend was still there. Those in the lowest serum magnesium group had twice the rate of heart failure as those who were in the highest group. So they're not saying it's causal, but there is definitely an association there based on this huge cohort study. So I thought that was kind of interesting. It's also associated with cardiac dysrhythmias. I alluded to that initially. This is an article from the journal Circulation, 2013, Low Serum Magnesium and the Development of Atrial Fibrillation in the Community. So atrial fibrillation is an extremely common atrial arrhythmia. I see it probably, I want to say probably every single day. I've got somebody coming in the emergency department with atrial fibrillation. It may be under control, it may not be, but it's just so common. The crux of this article is that low serum magnesium level is associated with the development of atrial fibrillation without structural heart disease, because other things can cause it too, valvular issues, that sort of thing, just aging of the electrical conductive system. So what they say in their conclusions here, low serum magnesium is moderately associated with the development of atrial fibrillation in individuals without cardiovascular disease. So they didn't really have any other reason to develop atrial fibrillation that they could identify other than low serum magnesium. Because hypomagnesemia is common in the general population, a link with atrial fibrillation may have potential clinical implications. Yes, I think so. Further studies are warranted. Yes, they're always warranted. So this is, again, atrial fibrillation, extremely common. There is definitely an association there. Now, there were some studies that showed that, maybe giving intravenous magnesium can help control atrial fibrillation, maybe help it convert a little bit more quickly. Those have not really panned out. I would love to see some more studies on those. I do, when I have somebody with atrial fibrillation that I'm having difficulty controlling their rate, I do tend to, at least, I want to make sure all of their electrolytes are within normal limits. And so it's not uncommon for me to uncover low serum magnesium in those patients, and I do try to correct it. But how much of a difference it makes, it's, at least in the acute setting, it's a little bit hard for me to say right now. So if any of you guys out there are cardiologists, I would love to hear your thoughts on that. So, okay, let's circle back here to that previous article that I showed you. This is a really important little diagram that was right on the front page of it. And at the top here, we have hypomagnesemia, and the causes here, low magnesium intake. We haven't touched on genetics. I pulled up a couple papers that went into excruciatingly painful detail on the number of different genetic polymorphisms that are related to poor magnesium absorption, excessive magnesium excretion, it was just way too much stuff to go into. But just keep in mind, I mean, there are genetic conditions that that can make somebody prone to low serum magnesium levels, and in those cases, we don't have any good solid guidelines on what to do with those people, but it makes sense that they would need to supplement perhaps with higher amounts of magnesium than the general population. And then they mentioned medication use here as well. So low serum magnesium associated with worsening insulin resistance, poor glycemic control, and then oxidative stress. And then it's also associated, as I mentioned, with worsening rates of increased rates of heart failure, atrial fibrillation, ventricular arrhythmias too, but AFib is one that we just mentioned, and then microvascular complications, which is really one of these are some of the more devastating things that happen to people with uncontrolled diabetes type 1 and type 2. Their kidneys fail. Many of them end up with chronic kidney disease or on dialysis. Neuropathy, they have severe pain, typically starts in the toes and the feet and works their way up. Retinopathy, which can ultimately in some cases lead to blindness. These are all associated with low serum magnesium levels. They boil it down to these essential points, which I think are important. And they say here, hypomagnesemia independently contributes to the development of atrial fibrillation, heart failure, and microvascular disease in people with type 2 diabetes. Magnesium is involved in several molecular mechanisms that may explain the relationship with heart disease, including mitochondrial oxidative stress. Absolutely. The potential protective effect of magnesium on development of microvascular complications is largely explained by biochemical pathways that are activated upon hyperglycemia. Magnesium supplementation in people with type 2 diabetes has favorable effects on blood pressure. I'm going to talk about that in a second. It's a bit overrated, in my opinion, but worth talking about. Lipid levels and endothelial dysfunction. Long-term, and this is the key here, long-term magnesium supplementation studies are needed to determine whether increasing serum or plasma magnesium levels can improve cardiovascular outcomes. So all of these things are associated with low magnesium, and it would make sense that supplementing with magnesium to bring your levels up into the normal range would, significantly improve these. We just need these studies to be done to kind of nail that down. But I think ultimately it makes sense that would be the case. But you know how it is with science. I mean, you have to have the studies that definitively prove it before we can say 100% that that's the case. So in my opinion, that's not a reason to not consider supplementing with magnesium. Okay, let's briefly talk about the medicines real quick, because this is again super common. Thiazide diuretics, hydrochlorothiazide, chlorthalidone are the two big ones. They're used for treating hypertension, and then loop diuretics. There's things like Lasix, which is used to treat heart failure and a number of other conditions as well. These they just tell the kidney to start dumping magnesium. Okay, so you pee out magnesium. So you can see if you're a type 2 diabetic or pre-diabetic, you're already excreting out an excessive amount of magnesium in your urine due to the nature of your condition. Then you add in a loop diuretic or a thiazide diuretic, which is very common in those people, and now you're dumping out even more. You're just peeing out tons of magnesium. Okay, and the other one is proton pump inhibitors. So these are like your little purple pill, your Nexium, Prilosec. Prilosec, I believe, is over the counter now. Most places, I know at Costco you can get a lot of it there. It actually inhibits the absorption of magnesium by altering the gut microbiome. So it's a little bit unclear to me exactly how that works, but it makes sense. And they're quoting in these papers a rate of like 5 to 15% of people who use these drugs chronically experience a low serum magnesium level. So these PPIs are wonder drugs in some ways for the treatment of gastroesophageal reflux, gastritis, esophagitis, that kind of stuff. But they really should not be used long term, in my opinion. They've got a whole host of other potential negative effects in terms of bone density and things like that when you use these chronically, but they also lead to low serum magnesium. So, I think they're best used for short periods of time. Consult with your doctor whether you feel like you need to be on something like that chronically, because there's definitely some downsides to it. There are certain antibiotics that if you use them, especially in high doses. Now, typically these are like aminoglycoside antibiotics, so we don't use a ton of those anymore, but they do get used on the inpatient side, they're directly nephrotoxic to a certain extent, so you got to be careful with those, and that likely has something to do with why those people experience, at least up to like 30% of them experience low serum magnesium levels. And we don't see this very much anymore, at least I don't as much, but mTOR inhibitors like rapamycin, which is a anti-rejection drug. So typically, like I used to hand that stuff out a lot on the inpatient side as a resident, when like for kidney transplant patients and stuff like that. It's a fabulous drug. Rapamycin is very popular in the anti-aging world. It has some extraordinarily interesting and powerful geroprotective properties, at least in animals and probably in humans. And so there are a lot of people that use rapamycin on a once weekly basis in an attempt to slow the aging process, which I think is fascinating. And I'm going to do another video on that because I think it's pretty cool. But whether, we know that like in the transplant patients, we used to see low magnesium all the time. But the rapamycin doses were really high, like 20 milligrams a day sometimes. Whether that happens with people who are just like microdosing rapamycin like once a week, I don't know. I can't really say. I don't think anybody's ever looked at that, but it's just something to be aware of if you're in the rapamycin crowd. That you just want to keep an eye on your serum magnesium levels. And obviously transplant patients, the reason they got an organ transplant is because they weren't that healthy in the first place. So they may have a whole bunch of other reasons why their magnesium levels are low. Digoxin causes this. Again, digoxin is typically used for atrial fibrillation, symptomatic heart failure. It's pretty old school. I don't see a lot of digoxin being used anymore. It's got a very narrow therapeutic window, so I've seen a lot of old people run into trouble with it when their kidneys start to fail and they start, developing other electrolyte issues like hyperkalemia. So I'm kind of glad it's kind of fading away. We have way better ways to treat those conditions now than digoxin, but it's still out there. Beta agonists. So beta agonists are used a lot for the treatment of asthma and COPD. So this is your albuterol inhaler. So people that are chronically using beta agonists or overusing their inhaler, if you look at asthmatics that use their inhalers, more than a couple times a week, low magnesium, it's about 30% of those people. So just as an aside, I see a lot of severe asthma in the emergency department. If you should not have to really use your beta agonists hardly ever. If your asthma is well controlled. So if you're using your asthma inhaler, your rescue inhaler, more than once or twice a week, whatever maintenance program you're on or whatever other treatments you're using need to be modified. So get with your doctor about that. But beta agonists, this in my world sometimes becomes an issue when I get, again, these severe asthmatics come in and we are just flogging their beta receptors with, round after round after round of nebulized albuterol. We not only have to keep an eye on their potassium, but we also have to keep an eye on their magnesium. So just something to be aware of. Okay, let's briefly touch on blood pressure. These are two articles here that this is where I got the information I'm going to share with you. This is from the journal Hypertension, August 2016, Effects of Magnesium Supplementation on Blood Pressure. This is the other article here from Nutrients, 2021. Effectively prescribing oral magnesium therapy for hypertension, a categorized systematic review of 49 clinical trials. Okay, I'm not going to go over all 49 clinical trials with you guys. Overall, there does seem to be an effect in certain cases. It's not super impressive, as I'm going to show you here in a second. If you have high blood pressure but a normal serum magnesium level, taking additional magnesium is not going to bring your blood pressure down. Okay, so it's only for people who are on antihypertensive medication and are either totally uncontrolled or just partially controlled. They do seem to benefit. The levels tend to be, you have to give quite a lot, sometimes up to 600 milligrams per day in order to see a clinical effect. And the clinical effect itself is not that great, as I'm going to show you here in this chart. Here, looking at changes in systolic blood pressure here in the middle. The bottom one, changes in diastolic blood pressure as compared to the dose of daily magnesium here on the x-axis. So they looked at at least these bottom twos, which is what we're going to look at, doses between 100 milligrams and up to 700 milligrams. So the systolic blood pressure, which again is that's that top number, you didn't get any effect at all until you got up to at least 300 milligrams a day of additional magnesium, and then you start seeing that line start to deflect a little bit. But even like past 600, approaching 700 milligrams, you're looking at about, they said an average of like 4 to 5 point drop, which, that's not bad. And, again, there are many other benefits to supplementing magnesium, but it's not a dramatic drop in blood pressure. And then the diastolic, as you would expect, that's the bottom number, a little bit less of an effect. So at the most, as you approach 700 milligrams and are over 600 milligrams, at the most you're getting like 3 to 4 point drop in your diastolic blood pressure. So, if you are on blood pressure medication already, and maybe you're just a few points away from your goal, then maybe you'll get there with a little bit of added magnesium. But this is not a wonder drug that's gonna, it's not going to keep you off of blood pressure medicine. Let's put it that way. Magnesium supplementation alone is not going to be effective as monotherapy for treating hypertension. Okay, getting on to cholesterol, there is a modest lipid lowering effect in patients that have low serum magnesium. This is the journal Biological Trace Element Research. It's a fascinating journal. May 2020, effects of magnesium supplementation on lipid profile among type 2 diabetic patients. And so this is just a meta-analysis. They looked at 12 different studies, and they found an average drop in LDL levels of about, give or take, right around 6.8 milligrams per deciliter. So pretty modest. Again, this is in people with type 2 diabetes compared to controls. No effect on triglycerides, no effect on total cholesterol, and really no effect on HDL. So if your sole reason for taking magnesium is to lower your LDL, don't expect dramatic changes there. Okay. All right. I'm not going to wade too deeply into the controversy about the different types of magnesium. There are a lot. There's like at least 10 that I'm aware of. The aspartate, citrate, lactate, gluconate. This is a study here from the journal Magnesium Research, 2005, study of magnesium bioavailability from 10 organic and inorganic magnesium salts in magnesium-depleted rats. So, in rats, take it for what it's worth. What they found was that magnesium gluconate appeared to be the most efficient compared to other forms of magnesium, such as like magnesium chloride. They've mentioned some other studies here that were relatively small, also with animals. They found magnesium in the aspartate, citrate, lactate, and chloride forms is absorbed a bit better than magnesium oxide and magnesium sulfate. We have to keep in mind, though, the effect is relatively small, and the cost differences between these types of magnesium could be significant. So I'll leave it up to you. I know there are some people in the naturopathic world and functional medicine world that have very strong opinions about this, many of whom are in the business of selling magnesium supplements. So magnesium gluconate, probably the way to go. Maybe aspartate or citrate. You can make an argument for those, but look at the cost and just keep in mind that the effect is not massive. Okay, if you're pinching pennies, I would go for the cheap stuff. Okay, you're still going to get a clinical effect. It may just not be as high as with these other fancier different magnesium salts. So anyway, enough on that. Okay, let's finish up with some strategies to increase your serum magnesium levels. Like anything, it's best to get all of this stuff from a healthy, well-balanced, well-rounded diet, okay? So there's a lot of magnesium in almonds, avocados, spinach, black beans, all of which I think are delicious. So ideally, you should be, at the very least, hitting your RDA using primarily those kind of foods. But, I understand that it's tough, okay? Increasing your dietary fiber will help. There's some data on these SGLT2 inhibitors. If you're a type 2 diabetic, or if you have heart failure, they're really good for those conditions. You might get a little bit of assistance there in recouping some of your magnesium, but really you should be focusing on dietary sources if possible. Having said that, it's not unreasonable, in my opinion, to supplement with magnesium. I think 400 milligrams to 800 milligrams at bedtime is a reasonable thing to do. That is what I do. I'm not telling you to do that. I'm not giving you medical advice. I would actually recommend that you talk to your doctor about this. But given the prevalence of hypomagnesemia, and especially if you're a type 2 diabetic, you have to be conscious of this. So again, just to sum up, I would focus on the dietary sources. These are all foods, by the way, that you probably should be eating anyway for overall health, and you just happen to get some extra magnesium from them. But I think in many cases there is going to be a role for supplementation. Again, I take between 400 and 800 milligrams at bedtime. There can be a gastrointestinal effect if you go above that. Just be aware. I'm not going to go into that in more detail. You can probably figure that one out on your own. So just be aware of that. Talk to your doctor about it. But just to sum up, this is low-hanging fruit. But having a suboptimal amount of magnesium can have some pretty serious health implications that, again, I think can fly under the radar. A lot of physicians don't think to check this routinely in their outpatients. We do check it on the inpatient side and in the emergency department, I think, a bit more, just because we're more acutely aware of some of the acute problems with it. But it can have a significant effect on a number of chronic disease conditions, not the least of which is type 2 diabetes, which we just mentioned. So anyway, some food for thought there. I hope you guys enjoyed this. If you have any particular experiences with magnesium, please let me know. I always love to hear from you guys. Take care.